Optimising Pulmonary Fibrosis Care. Mohammed's story. This is Mohammed. He's 68. He runs a post office convenience shop with his wife, Sharon. Mohammed is overweight, which his GP has been monitoring for a while. When he became breathless, he didn't want to bother his GP, but Sharon was insistent. At the surgery, the GP did not listen to his chest, but did refer him to a respiratory clinic. The clinic gave him inhalers and steroids, thinking he had COPD. But he developed a constant cough and struggled for breath on even the slightest slope. Both Sharon and Mohammed were under enormous strain. Why wasn't the medication helping? The GP sent him back to the respiratory clinic, where a consultant listened to his chest. Finally, many months after his first symptoms of breathlessness, he was diagnosed with pulmonary fibrosis, a condition that was gradually scarring his lungs. He started antifibrotic medication to help slow down the illness. Gradually, though, his health worsened and he needed to use oxygen at home. Sometimes, when he couldn't catch his breath, he would have panic attacks. Twice, after Sharon dialed NHS 111, he was admitted to hospital with a chest infection. The end-of-life care team did their best to support him at home. But when another crisis came, Mohammed was rushed to A&E, which is where he died. Unfortunately, opportunities were missed that could have made a big difference to Mohammed. What could have happened differently? When Mohammed initially felt breathless like before, he made a GP appointment. But this time, his GP did listen to his chest. Hearing abnormal crackles at the base of his lungs, the GP immediately referred him to a breathlessness clinic. The clinic did a CT scan and spirometry test to check his lung function, and fast-tracked him to a specialist service for interstitial lung disease, where he was diagnosed with pulmonary fibrosis and soon started antifibrotic therapy. The specialist team referred him to pulmonary rehabilitation, a dietitian and psychologist, and the charity Action for Pulmonary Fibrosis for support. He monitored his own lung function at home, and the specialist nurse checked in regularly. His condition progressed, but since the GP made a rapid referral onto the right treatment pathway without delay, he had started antifibrotic therapy much sooner and his decline was less dramatic. The community respiratory team started him on oxygen at home, and the breathlessness management clinic helped with his anxiety. Being in better shape, a lung transplant might be an option for him. Although there's no cure, the team helped Sharon support him through his illness. All of this made a big difference. Mohammed was happier and healthier in this scenario, and it gave him more time with his family. So, how can services turn around care for people like Mohammed? GPs should always listen to a patient's chest for basal crackles. Refer without delay for rapid access to the benefits of treatment. And streamline patient care by following an integrated pathway approach. If you are a healthcare professional or commissioner and want to know more, join our work to improve NHS services for people with pulmonary fibrosis at actionpf.org.